This UCSD TV program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest programs. The Sam and Rose Stein Institute for Research on Aging is committed to advancing lifelong health and well-being through research, professional training, patient care, and community service. As a nonprofit organization at the University of California San Diego School of Medicine, our research and educational outreach activities are made possible by the generosity of private donors. It is our vision that successful aging will be an achievable goal for everyone. To learn more, please visit our website at aging.ucsd.edu.
We are thrilled to have our speaker tonight, Dr. Deborah Kado. She's an associate professor in the Department of Family and Preventative Medicine and Internal Medicine here at UC San Diego. She has clinical expertise in internal medicine, geriatrics, and metabolic bone disease, with a special emphasis in treating osteoporosis. She also serves on the Stein Scientific Advisory Board. We are thrilled to have her here tonight. Please join me in welcoming Dr. Deborah Kado.
Thank you so much, Danielle. It's really a pleasure to be here and to see such a great audience interested in the aging spine, because it's one of the topics of interest for me for at least the past 17 years. So we'll see where we've come in the past 17 years. Let's see. But first, I must begin with disclosures, just because I like to maintain equanimity, but for sure I want to disclose that I have received either research funding, sat on data safety monitoring boards, or have received speakers' fees from the following companies: Amgen, Procter & Gamble, Medtronic, Kyphon, Octapharma, and Takeda. So I'm going to begin this lecture really just talking about some of the main things that affect the aging spine. The first one being osteoporosis. Now, osteoporosis really refers to the thinning of the bones that leads to decreased bone density and increases the risk of fracture for any individual. And here you see on the top pictures really good bone density, and to the right of that not so good bone density, where you can imagine if someone fell over, they might actually fracture their spine. Then there's a condition called osteoarthritis, which I'm sure most of you, or not all of you, have heard about, which refers to the inflammation of joints. So this other picture shows an osteophyte, which is develops in response to inflammation, and it is a painful condition. So a lot of times when patients come to me in clinic, they say, oh, I'm in so much pain, I have osteoporosis. Really, osteoporosis does not cause pain unless there is a fracture. So it's really a silent disease until there is a fracture. But osteoarthritis, on the other hand, is an inflammatory condition that is associated with pain. Then there's something called degenerative disc disease that refers to the discs that are in between the different vertebral bodies. And when we're young, there's nice cushioning. They're like little pillows that are in between each of our spinal vertebrae, but these tend to get dehydrated with time. You can lose the joint space, and when the bones are sitting right on top of each other, it can be also sometimes painful. And then finally, there's something called hyperkyphosis, which up until recently has not really been talked about so much. And this is where I'm going to be spending the most of the time talking about. And that refers to the forward curvature of the spine. And the X-ray here on the right depicts someone who's suffering from progressive curvature of the spine that tends to happen with aging. So actually, a bit surprising that not more is known about hyperkyphosis because it is one of the most common age-related spinal conditions. It's often referred to in the public as the dowager's hump, and that it's thought to affect predominantly older women. And this term, I actually looked it up, started in England in about the 1940s. It's also been called the widow's hump, again, implying that this problem affects predominantly women. But in fact, it's not that well understood, and as of 2013, I have to say, unfortunately, there are no proven effective therapies to prevent its progression in older persons. So, if you're a clinician like I am, and you come up with a clinical problem, and you think, wow, this is a problem that we need to be able to treat. How do we go about doing that? We don't really learn that in medical school. So a lot of us have to go for further research training to figure out if we have an important clinical question, how can we go about answering that question? So the first way is something called epidemiologic studies, which are studies of human health that occur in large human populations. So that's, for instance, how we figured out that smoking is bad for you, or heart disease risk factors. So if we can have large population-based studies, we can get a better idea of who is affected by hyperkyphosis, what is it caused by, are there any consequences that we should be worried about, etc. So I'm going to highlight two studies that I have used over the years, the study of osteoporotic fractures and the Rancho Bernardo study. In addition, one cannot dismiss the importance of laboratory research because unlike humans, things like mice or fish or flies don't tend to live as long, and you can control them more under experimental conditions. And it is true that actually mice, even though they're prone all of their lives, do have changes in their posture with age, believe it or not. So for instance, the black mouse has an evidence of a spinal hump there that the white mouse, as it gets older, does not have. So there are variations, and perhaps we could learn something from our mouse counterparts. And finally, once you have information from epidemiologic studies, how do you go about translating that information into helping your patient in the clinic? So in order to do that, we have to develop intervention studies where researchers can test whether particular treatments, drugs, exercises, whatever, might help prevent the problem, treat the problem, or prevent recurrence of a certain health problem. So these are ways in which clinicians can go about trying to improve the health of people who are affected by certain conditions. So, more about hyperkyphosis. Well, how does one go about measuring it? And what actually does cause it? And is it associated with anything that we might want to know about? And in fact, is it something that we can prevent? So, this is the Cobb angle measurement of hyperkyphosis. It was developed in the late 1940s by a guy named Cobb. Originally developed to look at scoliosis, but can scoliosis is the S-shaped curve in the spine, whereas kyphosis is the forward bending of the spine. And it can be applied to X-rays. So this is a lateral spine X-ray where researchers can then take lines and extend them, usually from the top of thoracic vertebral body 4, because you can visualize that top angle very well, and the bottom of T12. And if you were to extend those two lines all the way and looked at the intersection, that would be the angle of kyphosis. And if you remember your geometry, if you actually take the perpendicular lines and look at this angle, that angle would equal this angle. So that's the angle of kyphosis. In normal people, it's reported to be about 20 to 40 degrees. There's also something called the Debrunner kyphometer, which is a nice measurement because you don't have to do an X-ray to get a sense of how kyphotic somebody is. It was developed in Switzerland. It's no longer being made, but it's essentially a protractor on the end of two arms with two wooden blocks that are flexible, and the examiner would then place the two wooden blocks at the top part and then the bottom part of the spine and read off the angle. And the correlation between the Cobb angle and this Debrunner kyphometer is pretty good. So the range is also around 20 to 40 degrees. The English researchers developed a very nice and simple, cheap method to measure kyphosis, which is using the architect's flexicurve, which is a ruler basically that's flexible and can change shape in the same plane such that the examiner can ask the patient to stand up straight, put that flexicurve ruler onto their back, then it maintains its shape, take it and put it and trace it on a paper, and they get something that they call the kyphotic index, which is, can be translated into an angle, but it's again another measure of kyphosis. Then we have our locally discovered way of measuring kyphosis. Dr. Elizabeth Barrett-Connor, who's the principal investigator of the Rancho Bernardo study, of whom you may have heard of and might know the study. But this study was started back in 1972 to better understand cardiac risk factors. But in 1988, she was able to get funding from the NIH to better understand osteoporosis. So she had some of the participants come back and get bone density scans, and noted that when they were actually getting their scans done, some of the older participants could not lie flat on the table without having to really bend their head back in order to get comfortable. So she got the idea, well, why don't we put some blocks under their heads to get them to where they can be comfortable, and why don't we quantify how many blocks people need to be able to have a neutral head position. Then there is the quick and easy method that clinicians could use, which is just a qualitative assessment. And this is a very famous photograph that you can find on the internet from Japan that kind of shows how posture can change with time. And just by opening your eyes and looking around the community, you can see people who suffer from this condition. So the next question is then actually, okay, I think I've seen people who have this problem. I, in fact, may know people who have this problem, but how many people actually suffer from hyperkyphosis? So this is a study from the Johns Hopkins University where they recruited about 230 people aged 59 and older, men and women, to come to the clinic, and they had their examiners just kind of rate. Do they have any hyperkyphosis? Is it mild, is it moderate, or severe? So a very gross estimate. But the interesting thing about this graph that I pulled from their paper was that actually most people suffer from some degree of kyphosis, but let's just take the moderate to severe, because some people might just have bad posture and it doesn't mean anything. But even if you just take moderate and severe, you're talking about 30% of this population that was studied at Johns Hopkins has hyperkyphosis. With all of that, all these people being affected and the aging population, remarkably little is known. It's associated with aging. It's reported to be more common in women. It's reported to be a consequence of osteoporosis, meaning vertebral fractures and low bone mineral density. Because of that underlying pre-existing opinion, most studies of hyperkyphosis have involved subjects with known osteoporosis, and that if there are any bad things that happen to people who have hyperkyphosis, it's been assumed, well, that's just because of the osteoporosis. So they've been kind of thought to be synonymous entities, which in fact may not be the case. If you go back to those early studies with Milne and Lauder from the UK, when they tried to look at how much of their hyperkyphosis in their women was explained, actually they looked at men and women, could be explained by underlying vertebral fractures, they only came up with about 48% of the variation in these people who are older. So clearly something else was leading to this problem. But because maybe it was published, small study published in Age and Aging, which is not really a widely circulated journal, it didn't get a lot of notoriety. Now I'm going to step back a little bit and talk about spinal osteoporosis, because spinal osteoporosis is a little bit difficult in that when you talk about hip fractures or wrist fractures, you don't have to be a radiologist necessarily to look at a film and say, for instance, that bone looks broken. I mean, there's a crack right there. I mean, that's clear. But vertebral fractures, you can't even get the expert radiologist to agree what a vertebral fracture is. We spent a lot of time, at least the past 20 years, working on a good definition of what a vertebral fracture is. And that is because when you get a vertebral fracture, it represents a continuous deformation of bone. It's kind of a matter of degree. How deformed is it? And what degree of deformity equals a vertebral fracture? The other problem with vertebral fractures is that it's been shown in multiple epidemiologic studies, the first one shown at Mayo Clinic, data from the people who live in Rochester, Minnesota, that only 1/3 of these fractures come to clinical attention. So 2/3 remain underdiagnosed. In fact, I was just at the bone meeting this year where they were looking at men, and only 1 in 7 men in the Mr. Oz study knew that they had a vertebral fracture. So most of us don't even know we have one if we have one. And now in 2013, there's more of a consensus of what constitutes a vertebral fracture, by the way. The other thing is low bone density is used to diagnose osteoporosis. So it's possible that low bone density itself could lead to some vertebral body bowing that without a clear deformity that could then predispose someone to becoming hyperkyphotic. And this person doesn't have a vertebral fracture but is mildly curved. So I'm going to step back here to kind of say, well, how did I get involved with this area of research and clinical interest? And this is, I have to go back to Dr. Steve Cummings, who was my mentor at UCSF and was so dynamic back in the early 1990s saying, you know, osteoporosis is a big problem. We don't even really have any drugs yet to treat it. And we know that if you get a hip fracture, and 1 in 6 women will get a hip fracture, 25 to 30% could die in the next year. And if you have a vertebral fracture, by the way, only 1/3 know they have them. But the Rochester, Minnesota data has published that if you have a vertebral fracture, you're more likely to die. But 2/3 of the people don't even know they have a vertebral fracture. So that seemed like an obvious question to ask when I was a fellow. And I had the data available to me to answer that question. And what we did find by, because there were 9,575 study participants from 4 areas across the United States who were willing to come in and get baseline lateral films done, and we had a very good way of measuring vertebral fractures. And I looked at those data and showed that yes, whether they knew they had them or not, the more fractures they had, the more severe fractures they had, they were more likely to die over the next 8 years. And the reason for their earlier death was not explained just because they were older or they didn't exercise as much or they were smokers or had other health conditions. So it wasn't clear why were they dying so much more than the other people who didn't have vertebral fractures. This is a graph from that original paper just kind of illustrating that with increasing number of vertebral fractures, there was increasing rates of mortality. Very clear dose response. More fractures, worse chance of dying sooner. Also during that time, I had another mentor, Warren Browner, who had published in The Lancet back in 1991 out of these same women from 1986 that if they had lower bone density, they were going to die. They had a higher risk of earlier mortality. Well, when I came around in 1996, I thought, well, gosh, if you have low bone density and it's bad to you, I wonder what happens if you have more rapid bone loss. And these women in their study had repeated measures of bone density. So we looked at rate of bone loss, and certainly we found that if you lose bone more rapidly, your risk of dying also increases, and that the risk of dying is not easily explained by just, say, being older or other possible confounders. This is a graph from that paper showing that with increasing quartiles of bone loss, the risk of mortality certainly increases. So at the end of my fellowship, I thought, okay, well, this is kind of nice to see this, but I don't understand. I did all the statistical manipulation and I'm not figuring out why these people are dying sooner. Why are they dying sooner? So I went back and got the death certificates and tried to figure out why people might be dying sooner. And what we found was in both of these studies that the women who had vertebral fractures or had more rapid bone loss were actually more likely to die from a pulmonary or lung cause. Things such as pneumonia, emphysema, or chronic obstructive pulmonary disease. So then I had to think, wow, that's interesting. Why would that be? And then thinking, well, the vertebral fracture could potentially lead to more spinal deformation that could then compromise the lung function and cause these people to be at increased risk of death, so that if I were standing up straight and got pneumonia, I might have a better chance of surviving than someone who's all bent over. And at that time, actually, there were 600 women who had come through a guy named Bruce Ettinger, who's at Kaiser Northern California, who had done this flexicurve architect measurement in about 600 of them. And I found that these data were available. So the question was, I wonder if we can use this flexicurve measurement in these 600 and just see if are they at more increased risk of dying from a pulmonary cause. And Well, lo and behold, yeah, if they were more curved by the flexicurve measurement, they were at 2.6 times more likely to die from lung infection, for instance. But the interesting thing is that only 38% of those people who were the most curved by that flexicurve measurement had a vertebral fracture. So that's how I left UCSF at the time and went down to UCLA thinking, wow, we all call it osteoporosis, but it really isn't just osteoporosis, it's something else, and what is it? So with generous funding from the NIH and the NIA, and also continued access to this wonderful data set, the study of osteoporotic fractures, I was able to request funds to pull old x-rays from about 1,000 women who are age 65 and older in 1986. These women were from Baltimore, Minneapolis, Pittsburgh, and Portland areas, and measure using the Cobb angle their baseline kyphosis in 1986, and then I selected most of the women to have actually survived 15 years because the literature didn't have any information on how much do people progress with time. So it would be really interesting to see how kyphosis changes over time. And then to ask the question, well, how do vertebral fractures contribute to worse kyphosis and worsening kyphosis? What role does low bone density play? What about degenerative disc disease and other factors? And then also say and ask the question, if you have this condition, regardless if you have vertebral fractures or not, are you at increased risk for worse health outcomes? So let's start with the causes. So causes of hyperkyphosis in older persons actually include poor posture. Vertebral fractures, they're definitely an important cause. Low bone density and bone density loss. Degenerative disc disease. If your muscles are weak, you can't stand up straight. If you lose weight, it's not good for you. And there's reason to think that it might be an inherited trait. And this comes from my work with observing these mice, that it seems like it's an inherited phenomenon. So postural slumping. So postural kyphosis really refers to a flexible spinal deformity that develops because of poor posture. But if you remind people, you know what, you need to stand up straight, we can correct our posture. But one study did show that as we age, our ability to self-correct our posture does decline, such that by the age 65 and up, it gets a little harder to stand up completely straight. Can't ignore the importance of vertebral fractures in causing worse kyphosis. And through this study, we were able to show that with each prevalent vertebral fracture, meaning whatever fractures you have at any time you take an x-ray, if you happen to take it in a cross-section in time, that kyphosis is worse by about 4 degrees. And that we were able to track incident fractures over time, and that if you had an incident vertebral fracture, that kyphosis would progress about 4.5 degrees. And we were able to confirm that actually having low baseline bone density is not good for you, that it was associated with worse kyphosis, and that over time, over 15 years, having low bone density was a predictor of worsening kyphosis over time, and that actually looking at rates of bone loss, you lose bone more quickly, you're going to also progress your kyphosis more quickly. Degenerative disc disease was interesting. So the way we assessed degenerative disc disease in this population was actually just looking at the space between the vertebral bodies and calculating a ratio from the anterior part of the spine to the posterior. And what we saw was that if you had degenerative disc disease that with kind of a decrease in your height ratio of this area right here, that you were more likely to have worse kyphosis by about 3.5 degrees. But if you have that, you wouldn't necessarily have worse kyphosis progression over time. The other thing we did, because like I said, vertebral fractures are the way we diagnose them, it's a construct because it's a matter of how much deformity is actually a vertebral fracture. So I asked the question, well, what if we just took a continuous measurement of all the ratios anterior to posterior in the spinal vertebral bodies and average those and see how much of the variation of kyphosis is explained, because there are only those two major structures involving the spine, the vertebral bodies and the discs. And certainly when you look at the ratios anterior to posterior, the worse the ratios on average, you could explain about 85 to 89% of the variability in kyphosis. And this has been replicated in an Australian and also a British study, smaller studies, however. Muscular weakness seems like it should be associated with worsening spinal posture, and a researcher from Mayo who's been doing this for a long time did have measures of upper extremity strength in the 1990s and showed that it seemed to be associated with worse kyphosis. But in our study, where we had 1,000 women, we couldn't really do back extensor strength measures very reliably, but they did have grip strength. But there was no association with grip strength and kyphosis or kyphosis progression in these women. But it may be that grip strength doesn't really capture what's going on with your spinal muscles and your abdominal muscles, for instance. And those are the things that help you stand up straight. But more recently, in the Health ABC study, which is a large observational NIH-funded study that takes place in Tennessee and Pittsburgh area of older men and women, 70 to 79, black and white, they had CT scans done where people looked at the density of their spinal muscles, and it correlated that with degree of kyphosis. And certainly, the worse the lower the spinal muscle density, the worse the kyphosis. So there does appear to be some muscle component as well with regards to worsening kyphosis. Other findings from our study showed that women who reported a family history, meaning a biological mother or father who suffered from stoop posture with aging, they were more likely to have worse kyphosis at baseline. Also, skinny people, it's not good to be for kyphosis. And if you lose weight, certainly that's not a good thing. We did not find any significant association with health behaviors and kyphosis progression in this cohort. I have to say, though, remember how I selected these 1,000 women? I had limited funds, right? So I asked to study all the people who survived almost. I did select some who didn't survive, but it may be, we're getting at the healthiest population here who survived at least 15 years after the age of 65. Moving on to the consequences. So, unfortunately, it's not just a cosmetic deformity. A lot of patients come to me concerned because they don't want to get stooped over because it doesn't look good. But in fact, it's also associated with adverse health. In cross-sectional studies, which mean the measurement of the kyphosis was done at the same time as the measurement of the lung function, so you can't tell which is coming first because it's done at the same time, there is an association with worsening lung function, worse performance and physical function, worse self-reported physical function, and also people had reported increased injurious falls. But those are, you can't tell what came first. Now, longitudinally studied, meaning you take the kyphosis measurement first and look at physical function over time or fractures over time and, of course, death. This has been shown in multiple studies. So to spend some time with the Rancho Bernardo study, again, like I said, there were about 641 men and 937 women who were recruited to come to the osteoporosis component of the study back in 1988 and 91, and they had their kyphosis measured by the block method. They also had their physical function assessed both by a self-report and measured physical function. They also talked about whether they remembered falling in the past year and whether there was any injuries associated with the fall if they fell. And the women were followed for fractures over an average of 4 years. Also the men, but not very many men fractured over that period. And also they were followed for death over about 4.2 years. So the interesting thing about the Rancho Bernardo study, to Dr. Barrett Connors and also a little bit to my surprise, was if you look at the number of blocks, more blocks, worse kyphosis, you see that men are about twice as likely than women to have more blocks. So this kind of changed the paradigm of thinking, because prior to this it was always called the Dowager's Hump. Well, not in Rancho Bernardo. So if you actually spend some time looking at people standing up naturally in the community, you might notice that there tend to be sex-related differences in how the posture changes. Older men may tend to get more upper thoracic and cervical changes with posture with age, whereas women get the more upper thoracic, mid-thoracic changes. So when you look at the blocks measure and where it's measuring the degree of curvature, it kind of makes sense that men would be more affected by that particular way of assessing spinal posture. So what we found in Rancho Bernardo was that men are more commonly affected by hyperkyphosis than women if you measure it via the block method, and that if you had these more blocks, you were more likely to report worse physical function. You were having a harder time standing up from a chair without the use of your arms 5 times in a row. You had weaker grip strength, and you were at increased risk of having reported an injurious fall. Since then, these types of findings have been confirmed in the study of osteoporotic fractures, as well as the fracture intervention trial. The fracture intervention trial was the trial of 6,400 women who were randomized to either get alendronate, which is Fosamax, versus placebo, and we're able to show that Fosamax does help prevent fractures. But we only looked at the placebo arm of those women, and we're able to show that, in fact, if they had worse kyphosis by the de Bruner kyphometer, they were more likely to suffer from worsening time to get up and go measures of physical function. We also were able to show that hyperkyphosis in women, we haven't shown it in men yet, is associated with an increased risk of future osteoporotic fractures, and that it's not because they just had lower bone density or they had underlying vertebral fractures, which are a huge risk factor for future fractures. The other thing that has been interesting is that when we looked at kyphosis change over 15 years and then followed these women from years 15 to year 21, that those people who suffered from worsening change in kyphosis also had an increased risk of fractures over time. And finally, other studies have shown that people who get affected by hyperkyphosis are at increased risk for earlier death, and this appears to be somewhat independent of having an underlying vertebral fracture, which, remember, is the reason why I got into this whole area of research in the first place. So, based on the findings from Rancho Bernardo, it was clear that we had neglected to study another very important part of the population. And the NIH and the reviewers agreed that maybe we should better try to understand what's going on in the men. So we were able to recruit 1,800 men. Actually, the Mr. Oz study recruited 5,995 men from 6 areas across the United States. But again, for funding constraints, we were able to get 1,800 men aged 65 and older and measure the Cobb angle of kyphosis from their now digitized radiographs, so it makes it a lot easier. We are then looking at structural predictors of why men might have worsening kyphosis. And also now we have to ask, okay, it's fine, you've told me kind of like if you have vertebral fractures, you have low bone density, you're more likely to be kyphotic, but why? What is the underlying pathophysiology as to why these people are getting more bent over? So we're looking more at the muscle, sex hormones, and vitamin D. And also, we need to start coming up with an idea, well, okay, so kyphosis can get worse with age, but what degree of kyphosis should be considered not good? Like your doctor should do something about it. So we're trying to establish those kind of guidelines now. So the latest findings that were just presented just about last week at the American Society of Bone Mineral and Research were that in 996 men from the Mr. Oz study, they also had these sex hormones drawn, which included testosterone and estradiol and sex hormone binding globulin. And interestingly enough, what we found was that men with the lowest levels of serum estradiol had the worst degrees of kyphosis, and it was a very strong correlation, and it didn't matter what we adjusted for. Testosterone, however, there was nothing going on. So I don't know if you have been hearing NPR, heard the latest results with regards to a trial that looked at testosterone replacement, but then selectively trying to isolate out the effects of estrogen and physical function, that pointed out in the New England Journal that estradiol is probably having a very important effect in men. It's already been kind of shown that estradiol is important for bone health in men, but now we have something else to think about with regards to kyphosis. The other thing is I have a graduate student who's looking at the Rancho Bernardo study, and these results are a little bit preliminary, but in women who used estrogen in Rancho Bernardo, they had less kyphosis than the women who didn't use estrogen. So the whole estrogen question is probably going to be resurfacing for a lot of us after 10 years of having the WHI findings making us not use estrogen as a general rule, which I'm not dissing the WHI study. It needed to be done. A lot of us were giving Premarin and Provera, but now if we give it with great caution. Also, what I found out at this meeting is my colleague Elizabeth Samuelson from the Framingham study, and I don't know if you are aware of the Framingham study, but it's the Harvard-based study that gave us all the information about cardiac risk factors. Well, she went back to the NIA and said, you know, I think this kyphosis problem is important, and we have x-rays from the Framingham study, and maybe you can give us some money so we can go and measure kyphosis and see what's going on. So she reported at this meeting, and 193 women, mean age of 63 years, ranging from 50 to 79 back in 1975, where they measured the Cobb angle. They also happened to have serial pulmonary function tests over 13 years, measured as forced expiratory volume. And what she reported was that women who had more severe kyphosis at baseline then developed more decline in their lung function over 13 years of follow-up that was independent of problems such as smoking and vertebral fractures or other confounding factors, not actors. Anyway, so this was the first study that I've seen where it's actually shown that you have kyphosis at the beginning, that you're more likely to suffer from decrements in lung function over time. Okay, enough about the depressing stuff what is associated with kyphosis. What can we do? We're going to look at medications, we're going to look at postural awareness, exercise, orthotics and taping, and then 2 minimally invasive procedures, vertebroplasty and kyphoplasty. So, how about medications? Well, as I was describing to you before, the fracture intervention trial was a trial of alendronate, and I went back and looked at those 6,400 women and the Deborah Kyphosis measurement done at baseline and follow-up 4.2 years later, and found no difference with the alendronate-treated women. I got kind of sad because it seemed like if you're going to treat the bone density and prevent vertebral fractures, that there should be some benefit. And besides, back then, I think the drug companies were saying, and you're not going to lose height if you go on this drug. Well, when I went to the publication, I found out that the mean difference in height between the treated and placebo groups was only 1.5 millimeters. That's like nothing. It was statistically significant because they studied 6,400 women. I think that there's still room to think that the osteoporosis-related drugs may have a benefit. The Deborah kyphometer, if you actually use one, is a little bit tough to use, and I think assessing change, there might be just too much variability in the measurement to capture something real. Then the French, they have strontium ranelate, and don't be depressed that we can't get it here in the United States, because although it is approved in the EU for use and in Asia, in 30 countries, but not the United States or Canada, there's some pretty bad health side effects that are being reported, things that you wouldn't want. So I know people come in and ask me about it, but I wouldn't go out of my way to get it. Anyway, they show, though, that there are 2 randomized controlled trials. Women who were randomized to receive the strontium ranelate did have some less kyphosis progression of all of 1% over 3 years. So this is my favorite topic, exercises, because I really do think that physical activity and exercise is something that we should all be engaging in, no matter what our age is. And there have been at least 10 published studies that have come out, ranging from Brazil, Japan, Australia, Canada, but most of them have been in small, only 40 people involved, and they have all come across with mixed results. But this picture is of one of my colleagues in the middle, Wendy Katzman, who was a practicing physical therapist up at UCSF for many years before she realized that actually physical therapists don't really have any standard protocol for how to treat people who suffer from this posture, and yet she was seeing it in her practice. So she went back and got a doctorate in clinical research, and has since gone on to publish this her exercise to improve kyphosis, and there's a video that you can get on the American Physical Therapists Association website, and she told me at the meeting when I just saw her that it's actually been updated. But her study was interesting because she did pre-test and post-out tests of outcome measures in 21 women, so it wasn't a randomized test trial, but she applied her exercise, which I actually took her class about 5 years ago, went up there. It's a multidisciplinary multi-dimensional group exercise that lasts for about 50 minutes, and she uses the things that physical therapists use: foam rollers, stretch straps, handheld dumbbells. And she also told these women, just really think about your posture about 3 times daily and be conscious of how you're standing. The women in this little study had a mean age of 72, and their kyphosis was greater than 50 degrees. So you would be able to see that if you just happened to see them walking down the sidewalk. And her primary outcomes were kyphosis, and actually I think she used a de Bruner kyphometer for this. But there was an improvement of about 5 to 6 degrees over 3 months. And that also her back extensor strength in these women improved. So muscle strength improved, and they enjoyed the therapy. The other largest trial to date was a yoga intervention done up at UCLA of 118 older hyperkyphotic women, but I have to tell you, my patient was a man in his 90s who was in this class, so a few men. And there was a yoga intervention done 3 classes per week for 6 months with control activities, which were basically sitting in a classroom and having a lecture. And the primary outcomes were the kyphosis angle, also measured by the de Bruner kyphometer, but did not find any difference. And their physical function actually didn't improve. And I was a little puzzled by that, because it seems like a yoga intervention 3 times a week should improve functions. And so the only thing I can say is my patient, who I think was 91, came to me and he was a little disappointed. He said, "Oh, Dr. Kado, I'm so glad I had such a good time." And he had recently lost his wife, so he had a lot of female attention in the class. But he said, "You know, the last class was July 10th or something, and now it's August 6th, and they haven't done any of the repeated measures on me, and I feel like I'm losing my benefit." So I don't know if that could be a reason they didn't find something, but conducting primary data collection studies are hard to do, and maybe that's something that happened. But she looked at the de Bruner, the flexicurve measure, the architect's, and did publish that there was an improvement by about 5%, and there was a slight gain in height. This is actually a picture of some of the participants and the exercises that they did, which look like pretty basic yoga exercises for any of you who have participated in yoga. I have to talk a little bit about the spinal orthotics, although I must say they were not at the meeting this year. But from Germany, they've come up with this interesting contraption that you can put on your body. And there have been 3 published studies. That the first one reported an 11% decrease in kyphosis, which is pretty significant, and a 73% increase in back extensor strength. But it wasn't a randomized study, and you couldn't really tell what actually they were doing or how they measured the back extensor strength, so I remained a little dubious. Then there was the 4-week intervention of wearing the orthosis and doing the back extension and gait exercises. But they didn't actually measure kyphosis, but they said actually your balance and gait get better if you wear this. And then finally there was a flexible orthoses in 40 women who had osteoporosis, and they said it was great and they loved wearing it. I can't believe it when I look at it. But they also didn't say in the study how long the people actually wore this for. So it's really hard to make a lot of sense of what they were actually doing. The Australians, though, the physical therapists, are very interesting in that, I don't know if you've been to physical therapy, but oftentimes they can use taping. So they thought, well, maybe if you put tape along to help improve the posture, there may be an improvement. They only studied 15 people, but they did have a trend that there was some improvement in kyphosis. But they were also interested in balance, and they were interested in how the muscle responded by EMG recordings, and there was no difference with that. So it's a temporary thing, but maybe it's the same as kind of reminding someone if they can self-correct their posture to stand up straight. Then there's the vertebroplasty, which is the minimally invasive way to help treat someone who has suffered from a vertebral fracture. This was developed in the mid-1980s, where if someone has a vertebral fracture and they're in a lot of pain, the French physicians would then go under radiographic guidance, find the fractured vertebra, insert their needle into the spine, and inject cement that's very hot and then it kind of gels. And patients who get this will tell you that there's almost 100% improvement in pain almost immediately, and 60 to 100% of all the clinical case series that have been published throughout the world report very beneficial effects. But the bottom line is finally someone from, I think, Mayo and then Australia decided to do the randomized controlled trials, 2 separate ones that came out in the New England Journal in August of 2009. And those trials enrolled these patients to receive either the vertebroplasty or lidocaine injection in the back. And what did they find? The lidocaine injection in the back without all the risks of putting in a needle into your spine and injecting hot cement was just as good as getting the whole procedure. So the utilization of these procedures went down dramatically after the publication of those 2 trials, although you'll find orthopedic spine and spine surgeons very dubious, and they have a lot of criticism of the study. That being said, almost any research study is not perfect. Kyphoplasty, for those of you who have not heard of it, this was developed in the mid-1990s, and it's different from vertebroplasty in that they say it's more controlled because you insert a balloon tamponade into the fractured vertebra and inflate the balloon, creating an artificial space. You deflate the balloon, take it out, and then you put in the needle and inject the cement, and you get a much better result because you've created an artificial space, and that it should help support the vertebral body. There was a randomized controlled trial published about the same year in The Lancet, which was compared to usual care that reported some benefit, but I think all of the kind of negative press from the vertebroplasty, which is not much different, has made it that neither of these 2 procedures are that commonly used, although they do have some indications in certain cases. The main complaint or possibility of a problem that people worried about was when you put cement in the affected vertebra, it affects the biomechanics of the adjacent vertebra, and they might be more likely to fracture. So you get people who have repeated fractures because of, we don't know if it's because, but it's thought that maybe it could be because of the change in the mechanical properties of the spine. So, in 2013, this is where we are. We know that it's not just a women's problem, it also affects older men. And if it's not just osteoporosis, what exactly is this age-related change in kyphosis that we see? So we're working on understanding more of the biologic correlates by both looking at human populations and a little bit at the mice. And we now have larger studies that are currently being conducted with NIH funds to actually do a randomized controlled trial of Wendy Katzman's intervention that showed such promise in the 21 people. So now people are being randomized to either receive her exercises versus basically not receiving the exercises, and to see if there's any improvement in kyphosis. And also through a grant through UC Davis, the interest in sex differences and whether exercise can affect the sexes differently in terms of this exercise. And then since coming to UCSD, I have collaborated with some exercise physiologists here in the ePark Center and have been successful in getting some pilot funding from the university itself to better understand the effects of kyphosis and on balance. Because if you look at the literature, in fact, the Mayo Clinic investigators have written for years that, oh, you get hyperkyphotic, you're going to fall down. But if you scour anything that's been written, it's not clear that one is going to fall more often. But it makes sense that perhaps there's a change in gravity and that perhaps someone might be more likely to fall. So what we're going to do is more detailed measures of balance, looking at the different components of balance, the eyes input, the somatosensory, the input that we get from our feet so we know where we are in space, and also the middle ear input, the vestibular sense, and see are these at all affected in people who are more hyperkyphotic, and then also follow these people for about a year to see if they are actually falling more than people who are not kyphotic, because it's not clear what is actually the case. And the purpose and the reason why I am doing all this over the past 17 plus years is hoping that one day we will better understand what this aging phenomena is. And unlike gray hair, which we can just dye, maybe there's something, instead of just accepting that our posture is going to change and we're going to have to be bent over, there can be something that we can do about it to prevent it from affecting so many of older people. This woman on the left is a 1922 Mardi Gras queen who suffers from, I would say, about 53 degrees of kyphosis. Don't hold me to it, I haven't measured it, compared to the costume designer on the right who stands up tall and proud. I have to acknowledge the funding for most of this research is really coming from the NIH, which unfortunately has been shut down for this month, kind of barring further research. But the NIA and the NIAMS has been key in the people who work there and supporting the work that we do. Here at UCSD, Elizabeth Barrett-Connor has been a supporter for many years now. UCLA, Mei-Hua Huang does a lot of the statistical analysis, and Arun Karlamangla, California Pacific Medical Center and UCSF, where I started. There's Wendy Katzman and Steve Cummings, my original mentor, and people from all over the country and even the world are now getting interested in kyphosis. I was just speaking to one of the people here about a Polish orthopedic surgeon who's just emailed me, very interested in how better in using his methods of studying spinal curvature with aging. Thank you so much for your attention, and I welcome any questions. So the question was a personal medical question with regards to being on a medication called Evista or raloxifene, which is a selective estrogen receptor modulator that has been shown in clinical trials to prevent vertebral fractures, and with good efficacy. It's been on the market for many, many years. But the question is, what if you have a vertebral fracture despite being good patient and taking the medicine and doing what your doctor says? So that question is tough to answer without knowing the entire circumstance, but generally what I would tell medical residents or students is then if someone's fracturing on a medication that's been proven effective and you're sure that they're taking it, then you have to start thinking about underlying causes of why someone might be osteoporotic. So it might not so much be as much as a drug failure as is there something else going on that's kind of preventing the drug from doing its job. So it would require further clinical investigation to be able to answer definitively. So good question. The question is, oh, you mentioned exercise really enthusiastically, but I don't actually know what you're talking about. So I think if you Google standing tall and the American Physical Therapy, American Association of Physical Therapy, is it AAPT? Any physical therapists in the audience? Is that right? APTA, thank you. So APTA, and I think if you put in Wendy Katzman, Katzman, you may, or even Standing Tall is the name of her video. So you could actually watch her video on what exercises she does. So the question was with regards to scoliosis and how that might interact with kyphosis. Is there any association? And because they kind of seem related in that they're abnormal curvatures of the spine. This is a very good and thoughtful question. In the mice models that I've seen of accelerated aging, I do see evidence in some models of what we call kyphoscoliosis, so that there is an association. But both in mice and in humans, you can see either one in isolation as well. I would say perhaps one of the biggest things that are associated with both either kyphosis or scoliosis is the low bone density. Certainly, people who suffer from scoliosis do have an increased risk for osteoporosis. So the question was, how long should one really be on Fosamax? If you're on Fosamax, and maybe 10 years is enough. I think that actually the osteoporosis world has gotten a lot more complicated since Fosamax was first brought onto the market. And one of the reasons is, in case some of you have not heard about it, but there are increasing reports that now I think almost everybody involved in the bone world agrees upon that unlimited use of Fosamax over a lifetime, unless you have certain very severe medical conditions, is probably not recommended because a certain percentage of people go on to develop weird thigh fractures spontaneously. And I've actually had patients come to my clinic saying that they've been on something like Fosamax and they thought they were having thigh pain for a few months, and then all of a sudden they feel that they hear a crack in their thigh, and in fact it's cracked. So most investigators who are, and clinicians who are up to date, do think about how long one should be on Fosamax, and in fact, depending on what the situation is, I kind of use 5 years. And that 5 years is because of the fracture intervention trial, where they showed that the women who got randomized to the alendronate, after 5 years there was a great effect in preventing fractures and improving bone density, but then they wanted to do an extension and see, well, what if you get treatment for 10 years? Or what if you stop treatment at 5 years and then see what happens at 10 years? Or what if you don't get treatment for 10 years? And these women were wonderful. And so they agreed to be continued in this trial, followed for 10 years. And the women who got the medicine the entire 10 years actually had the best increase in the bone density and the lowest rate of fractures. But the women who took it for 5 years and then got the placebo for the next 5 years actually did pretty well. Their bone density was preserved, and they had a lower fracture rate than the women who never got the drug to begin with. So I kind of use those data to suggest if you've been on it for a while and you're doing well, you're not fracturing, you're not falling down, then you've paid your dues and you can come off that medication for a while and reassess the risk and see whether or not. Now we have in 2013 several different options for osteoporosis treatment. Wow, so the question is, what happens if you are unfortunate and have multiple crushed vertebral fractures that are associated with continuing pain? What would you recommend? Now that's a tough question, and for 35 years, and that's a long time. So it's not something that I can easily answer in this forum, but generally when the natural history of a vertebral fracture is that even if you did nothing, that the pain associated with that vertebral fracture should get better with time. Sometimes it does take 6 months to a year on average. It may be that something else is going on, and I couldn't really say. In general, though, before when I was in training, they'd say, oh, you get back pain, lie down until you feel better. But I think really maintaining function as much as one can is very, very important. So if there's not a danger of further harm by being more active, I definitely try to encourage the activity to get out of bed with help, because sometimes, you know, the human mind is very powerful. So just the power of distraction sometimes gets us to forget that we're actually in pain, and we can have a better quality of life based on that. So the question is, I've been reading about these low vibration plates. So one of my colleagues, Clinton Rubin from State University of New York, Stony Brook, has been studying this since I started in the field. I went past his poster when he was having turkeys stand on vibration plates. And I remember asking him, how are you getting those turkeys to stand there? He said, actually, they like it. Then he did the sheep. Then he did the persons, and now he has a company, but then that was called Juvent, and then they separated, and now he has another Meridian company, and I'm not sure what happened there, but I do respect the science. I'd have to say that Dr. Angela Chung from Canada, University of Toronto, just reported results of a randomized controlled trial in older persons. I think it was age 65 or older. It's not published yet because she just had an oral presentation, but the bottom line is there was no effect. Okay, well, thank you so much for your attention.